So it's a little, after hearing those presentations of things that are sort of really at the cutting edge, I'm afraid this is going to seem a bit mundane, and I apologize for that in advance. My friend Lonnie Reisman is here, and he was recently sending me a journal article from, I think, the Journal of the American College of Cardiology. And what it showed was that, people who have ejection fractions that are compromised and have congestive heart failure should be on 3 medications. And they looked across 18,000 patients with that particular ailment and what percentage of them were on all the right medications. And it turned out to be about 1%. So there's a tremendous gap between sort of what we know in terms of the medical literature and what really very good therapies can do in our utilization of them. And that's kind of what managed care is about. And what I'd like to talk about is, sort of how we're thinking about retail management of population health and how we can address those kinds of problems. And I would say this is sort of in light of our proposed acquisition of Aetna. We are today largely a big retail pharmacy chain and a very large pharmacy benefit management company. But we're thinking about ways in which we can get deeper into population health, and that's what's behind the proposed acquisition. But as you know, there's a series of sort of federal and state regulators that have to approve that. So I won't be talking at all about Aetna or any other specific insurer, but just kind of how we'd be looking at retail management from the point of view of the assets that we have. And I think the other thing that starts a discussion off like this is this particular statistic, which I think is relatively dramatic. I like to show a lot of statistics in presentations I give, but this is the only one that I'll show today. And what it shows is basically the amount of money that people have as disposable free income compared to what they could potentially owe as a result of the deductible they have on their health plan. And as the health plan costs, your costs of insurance are going up, and depending on sort of who you look at for the measurement, maybe Milliman is the best, $23,000 a year for a family. The average family, this is the average middle class family, only about 30 or 40% of them have enough free disposable income to cover their deductible. The whole point there is that our healthcare system is just rapidly sort of moving out of affordability for the middle class. And I like to say, we have a healthcare system today that we won't be able to afford in 10 years, especially with the demographic changes that occur in the country and the overall lack of improved productivity that's been pretty well demonstrated. So we have to do something different, and that's what we're thinking about. And the way that we think about this is that what we want to do is create a sort of new chassis for population management, and that chassis is very much data-driven. So there's a wealth of data out there, and everybody's talking about sort of big data and analytics and artificial intelligence, but there is some real promise out there in terms of accessing information today that we couldn't really access even 5 years ago, and then combine that with convenience and relative intimacy of a relationship with either a pharmacist or a nurse practitioner who can work with you on your problems and be in between you and your primary care provider, providing what we call complementary primary care. So it's a digital intelligence approach plus a human touch, and what we're trying to do is get the engagement, because those 99% of people who aren't taking those 3 medications, they're really lacking engagement with what they should be doing. And if we can improve that to sort of 50% of the people are taking the right medications, we improve human life. All of those people will do better and enjoy life more, and we'll also reduce healthcare costs overall. So this is about the sort of changing paradigm of health management. And I'd say, sort of if you look at managed care today, it still looks pretty similar to when I first got into the managed care game maybe about 25, 28 years ago, working at a medical center up in Massachusetts. It's still a matter of people sort of calling up on the telephone or going through sort of pre-certification for certain kinds of procedures. And we just think that doesn't work anymore. I don't know about you, but at my house today, nobody answers the landline when it rings. Most of the time, it's going to be a CVS pharmacist calling us anyway. So But what we're trying to do is basically sort of change that care engagement model, keep the patient at the center of it, and then supplement what's going on currently with appropriate sort of population health techniques that insurers are using, with our ability to sort of provide a healthcare coordinator and a CVS pharmacist and a nurse practitioner in a convenient location who are all on the same page with regard to what your care plan should be. Like, you've got that congestive heart failure. Are you taking all 3 medications? And then the important point for us is that we include the patient's PCP in that. The way that we look at it is that we're not going to buy up an entire layer of primary care and urgent care centers and ambulatory surgery and then play the hospitals off against one another. We see ourselves as part of the sort of medical home, with everybody having a primary care provider and part of the integrated delivery systems doing accountable care, because we think that's the best way to accomplish the best outcomes for patients. And I should say, from our retail clinic, Minute Clinic, last year we referred nearly 4 million people to a primary care provider. And we're by far the biggest referrers to primary care of anywhere in the country. And I won't have time to go through all the slides that I brought along, but this is really the sort of key one. We're looking at it from the point of view of keeping it pretty simple. So we've got targets, and we're initially sort of looking at sort of 3 targets. And then we've got 4 tools. And so, if we can break that down so that everybody can understand, the average person can say, what are you going to do and how are you going to do it? And the targets are basically 5 common chronic diseases, outreach to fragile patients, and better transitions. And the tools I've already talked about: coordinators, clinics, and pharmacy visits in an easy-to-get-to location, that is our stores, our 10,000 locations, enhanced digital and telemedicine outreach, and better monitoring of home activity, and finally connectivity to the provider. And I'll run through those real quickly, but what we're trying to say is we're trying to shrink the distance between the patient's everyday life and care engagement. So, and we think that our physical footprint is the big strategic value that we have associated with that. Our 5 common chronic diseases would be anybody else's 5 common chronic diseases: diabetes, hyperlipidemia, hypertension, asthma, and depression. I hope that the gentlemen who were presenting previously, I thought it was a fascinating discussion, if they can just come up with one thing that's as good as like metformin or atorvastatin, there'll be a tremendous sort of public health impact associated with that. All of these diseases are treated by and large with common generic medications, small molecules today. All of them have a really good biometric outcome that's all being digitized so that we can follow people and tell them how well they're doing on their outcome. That's the biometrics. And very specific things that we know that if we lower the hemoglobin A1C, we'll actually decrease the cost for that patient in subsequent years by $6,000 a year for 1 point drop in hemoglobin A1C. So this is a great area to be in, but it's just a matter of basic blocking and tackling through better engagement to make sure people are taking their medications and understand what steps they have to take next to lead a healthy life. Second is the fragile patient. We think that there's going to be much better information available in the home at a low cost that's going to provide us with insights through analysis of data about patients who are doing poorly and when to intervene. And we don't have to drag them into, like when I worked at the Brigham and Women's Hospital, the hardest thing for the patients was actually finding a place to park and getting in to sort of see the doctor. We're not dragging them in, we're bringing them into our 10,000 stores. The only reason we have those stores, the only reason about their location is that they're convenient. We don't care if they're across the street from Walgreens, as long as it's a convenient location. And be able to sort of bring those people in. And this is a sort of notion of owning the home that I'll talk about. We need to be able to get that information from the home. And quite frankly, most primary care providers are overwhelmed with the data they have right now, so they don't want to start getting a lot of signals about what's sort of going on in the home. And this is an area where productivity really improves. I remember 10 years ago when I was the chief medical officer at Aetna, I went and saw a house that GE and Intel, in a collaboration they had at that point, had wired up to be able to sort of tell what were the activities of the individual patient. It cost tens of thousands of dollars to do that, but they thought there could be a return on that. Today, I can go to a startup and get something that does just as good a job for about $200. So there is places in healthcare where we're seeing sort of real improvements overall in efficiency and productivity, and we need to be able to take advantage of that. So care for the fragile patient. And then the last thing is just monitoring transitions of care. And I'd run through this quickly. This group is, I see who's here. They all know unnecessary emergency department visits, unnecessary readmissions to the hospital. We think we can prevent a much greater percentage of those than has occurred before. So part of it is our retail clinics have to slightly expand in terms of sort of the services they're offering more in the direction of urgent care. And this is, again, a place where I see technology. I believe that we're going to have available point of service, CLIA waived, finger stick tests for a variety of laboratory tests that we would do, which really changes the nature of what you can do in a retail clinic or even in an urgent care, because you can get the information, the results right away. And being able to do that, there's a lot of things that we can do to prevent unnecessary visits to emergency departments. And we've demonstrated, we published a study 3 years ago in Health Affairs demonstrating that if you brought people out of the hospital, had them see a pharmacist, do a medication reconciliation, you can have the readmission rate. It's a very simple thing, but it's not the kind of thing the American healthcare system focuses on, because people in the hospital are focused on the hospital, and the people at home don't even know when the patient's going out of the hospital. So those are the kinds of things that we think we can do. And then the tools are relatively straightforward. I really have already talked about most of them. The first is that we would offer opportunities to be able to see us in the store, but that's going to be built on a layer of digital information. And we are, at least a big portion of what we are, is a retailer. We operate a $20 billion a year retail operation. So we understand a little bit about consumers, and we understand things about sort of how to keep track of people digitally, and we're expanding that. And that information, we figure there's a lot of information that can come in from sources that include claims data, electronic medical records, external data including social media, that if we put algorithms to, and algorithms increasingly that we're not designing de novo, but that we're letting the machine design and tell us where we should have new insights, that information can all come into a coordinator, a pharmacist, and a minute clinic nurse, who are then all on the same page in terms of sort of what is supposed to happen to the patient. We're an Epic user. All of our sites are up on Epic, and what we're finding in Epic is that there's good new programs being added to the App Store that allow really good care coordination for an individual. So they're not getting different signals from different parts of the overall organization. And we'll be adding more healthcare services into the stores. Some stores that we're modeling now will go to nearly 50% healthcare services. Many stores will be at a 30% level, but you'll see us adding more things in and getting rid of some more of the things that aren't as healthy in our stores. We got rid of tobacco about 4 years ago. We're moving into sort of healthy food. So make the stores feel much more like a place that's health, beauty, and healthcare provision. And the key thing, our key sort of strategic advantage, is nothing other than the fact that people can actually get in and see us. We got parking lots around the stores. We're convenient. And when, years of studying behavioral economics in healthcare, the one thing that comes through repeatedly is that convenience is the major factor to get engagement. So just trying to think back to that patient who's got congestive heart failure, who's got an ejection fraction is compromised. We can bring them in and see them. And we're not looking to sort of, visualize their heart. We're not going to operate on their vagus nerve. We're going to look at their blood pressure and see what their respiratory rate is and check the scales they've got at home against the scales we've got there and counsel them. That's what we're going to be doing. But that's really what's missing in the American healthcare system today. So enhanced digital and telemedicine outreach. We announced yesterday our relationship with Teladoc, and we're offering telemedicine visits now. You get on our CVS site or our Minute Clinic site. You can go immediately to a telemedicine visit, and beginning next year, our nurses will be providing telemedicine visits, and then we're incorporating telemedicine into the visits at the Minute Clinic so we can bring more specialty care into the Minute Clinics. So if there's specific things we need to bring a doctor in for, we can do that through telemedicine. We think that's a great expansion of sort of what you can do at a retail clinic, and we'll be heavily emphasizing use of digital devices to get information in on patients. And that's one place where we think we're really taking advantage of innovation in the healthcare system today. We'll try to own the home. So if the patient needs to be monitored at home, we're going to do that. And this is where we get sort of information on their activities and what they're eating. We'll get more into healthy food that's delivered to the home. And try to make sure we can keep patients who are sicker and sicker at home. And we talked to people today who are doing sort of hospital at home programs. And we can see that that's a good way to sort of reduce costs relatively dramatically, but it requires much more follow-up, and it requires the ability to sort of interact with those patients. It's probably going to require the ability to send more patients to the home, but fortunately, there's a lot of interesting organizations that can help us put those sorts of services into place. So just to give you sort of a sense about the simple way we see it, patients got a PCP, they're in an integrated system, patients got hypertension and diabetes. If they're at risk, what those PCPs want to be doing is seeing their really sick patients and making sure that they are being well taken care of and kept out of the hospital. But a patient with hypertension and diabetes, they need tuning. They need to get on the right medications. They need to get the right blood tests. We need to be following what's happening with their blood sugar and their blood pressure. The Minute Clinic nurses are great at that. The one big advantage that we have is visits to our Minute Clinic have net promoter scores that are above 80. It's almost unheard of in healthcare. Health insurance usually runs in the single digits. So people really like what happens in our retail clinics. And so the nurses are very engaged and much better at this, quite frankly, most studies would show than primary care providers are. We coordinate all that information around medications and things like that, and then we're wired. All this is on an Epic electronic medical record. We have already built 5 years ago the electronic connections to 12 other electronic medical records. Our notes go directly into those EMRs so that the PCP can follow up on that and then keep in touch with us about the care plan. We'll develop organic relationships with a lot of integrated delivery systems over time, but this is something that can occur outside of those organic relationships, and it's a closed loop that we think is really important from a coordinated care point of view. And these are some of the statistics on interoperability. In Epic, we're by far the biggest users of interoperability today, and we actually think that with the sort of changes that are occurring with Commonwealth and care equality, that we're going to be able to get the major sets of data that we need from any EMR. I think the EMRs are really opening up to interoperability. So it's a collaborative model. As I said, there's really two choices. One is to build your own layer of ambulatory care and then play the hospitals off against one another. And you can see some insurers are pursuing that, but what we're trying to do is something that would be called complementary primary care, where we're doing basic preventive primary care, engaging with the patients, making sure they're getting the tests they need, making sure that they're taking the medications that they need, and as a result of that, reducing overall costs. So we think that really complements the medical home and accountable care organizations. And the AMA continues to come out against our proposed acquisition of Aetna. But we are reaching out to the major primary care groups and having these discussions right now. And I think that they actually see the logic of what we're talking about. So in summary, kind of the way we're seeing about it is we're trying to fuse digital engagement and convenient care to create better engagement, so better quality, better coordinated care, support accountable care organizations, and work quite closely with integrated systems, as well as the medical homes that they've set up. And think about this as an infrastructure that's really sort of equal parts of integrated AI-evaluated data and physical space at convenient locations. So really straightforward stuff. As I said, relatively sort of mundane, but the kinds of things we need to do if there's going to be real population health management. And as I suggested, I think the country's going to need real population health management going forward. So thank you very much.